Endoscopic management of familial adenomatous polyposis in patients refusing colectomy. Introduction. Familial adenomatous polyposis, FAP, is caused by a germline mutation in the tumor suppressor gene adenomatous polyposis coli, APC. Most patients with FAP develop colorectal adenomas during their second decade of life, and half of these patients will develop colorectal cancer, CRC, in approximately the fourth decade of life if they are not treated at a younger age. To date, surgery is the only accepted method of preventing the development of CRC. Two major surgical procedures are used to treat FAP: colectomy with iliorectal anastomosis and proctocolectomy with ileal pouch anal anastomosis. Because patients with FAP are generally asymptomatic when diagnosed, some of them refuse to undergo surgery. Endoscopic surveillance with polyp removal has been used to prevent cancer development in the rectal stump after colectomy or in residual rectal mucosa after proctocolectomy with ileal pouch anal reconstruction. It has also been suggested that endoscopic polypectomy can be considered in the management of patients with attenuated FAP, which is characterized by fewer adenomas, a later age of onset for colorectal adenomas and cancer, and a decreased cancer risk compared with typical FAP. In the current study, the medical records of FAP patients who strongly refused colectomy and were managed endoscopically were reviewed to evaluate whether the endoscopic approach is feasible and safe in terms of adverse events associated with removal of numerous polyps and prevention of CRC. Background and study aims. Colectomy protects against colorectal cancer in familial adenomatous polyposis, FAP. However, some patients with FAP refuse surgery. The aim of this study was to evaluate the feasibility and safety of endoscopic management of these patients. Patients and methods. A retrospective review of medical records was performed to identify adult patients with FAP who refused colectomy and were managed by repeat colonoscopies to remove numerous polyps between 2001 and 2012. Polyps were removed by hot snare polypectomy or endoscopic mucosal resection. Polyps smaller than 10 millimeters and with no endoscopic features suggesting cancer were discarded without histological examination. The remaining polyps were examined histologically. Results. Of the 95 eligible patients, 5.3%, were excluded. The remaining 90 patients, median age at first visit 29 years, 46 males, were followed for a median of 5.1 years. Interquartile range, IQR, 3.3 to 7.3 years. During this period, a total of 55,701 polyps were resected without adverse events such as bleeding or perforation. The median numbers of endoscopic treatment sessions and polyps removed per patient were 8, IQR 6 to 11, and 475, IQR 211 to 945, respectively. 5 patients had non-invasive carcinoma, Category 4.2 according to the revised Vienna classification, detected within 10 months from the start of the follow-up period. All of these patients were treated endoscopically without signs of recurrence during a median follow-up of 4.3 years, IQR 2.0 to 7.1 years. No invasive colorectal cancer was recorded during the study period. 2 patients, 2.2%, underwent colectomy because the polyposis phenotype had changed to dense polyposis. Conclusion. Endoscopic management of FAP is feasible and safe in the medium term.